Good morning, everyone. This is Donna Frescatore. We'll be starting in just a few minutes. Thank you. Good morning, everyone. Thank you for joining us. This is Donna Frescatore, State Medicaid Director and Executive Director of New York State of Health. This morning's webinar is a briefing by the Office of Health Insurance Programs on the 2019-20 executive budget. We appreciate you joining us today. Here with me to do the presentation are a number of people from the Office of Health Insurance Programs. I'll introduce them, and then they'll introduce themselves as we go through our presentation. First, Liz Misa, Deputy Director of the Office of Health Insurance Programs. Greg Allen, Director of the Division of Program Development and Management. Janet Zachary-Elkind, the Deputy Director of the Division of Program Development and Management. Lana Earl, the Director of the Division of Long-Term Care. Michael Osborne, Medicaid's Chief Financial Officer. Jonathan Dick, the Director of the Division of Health Plan Contracting and Oversight. And Judy Arnold, the Director of the Division of Eligibility and Marketplace Integration. Today we'll cover a number of Medicaid proposals that are in the 2019-20 executive budget, including proposals related to pharmacy, long-term care, managed care, transportation, investments to improve patient care, and health home. Before we begin, we are going to take questions at the end of the slide deck. We have a team here who will watch your questions as they come in. Please enter them into the chat function. Today's webinar is being recorded. So with that, I'm going to turn it over to Janet Zachary-Elkind.
Hey, thank you, Donna. We'll start with reviewing the proposal related to over-the-counter products. This proposal does eliminate coverage for certain over-the-counter products and also increases co-payments from 50 cents to $1, aligning New York more closely with other states. As we made determinations as to which products would no longer be covered, we did ensure that we maintain coverage for clinically critical products, things like aspirin or vitamins and minerals that are used to treat deficiencies. And we also maintain coverage for those OTC products that are in the preferred drug program. The second bullet indicates the subset of OTCs and what categories they fall under. And finally, just to reiterate, the copayment exemptions will continue to apply to our most vulnerable members. And right now, those copayment exemptions apply to about 41% of all the claims that are processed for OTCs.
So this is Greg Allen. I'll talk about the established fair drug pricing models in Medicaid managed care. This proposal would increase the transparency inside of the Medicaid program for the prices that we pay for drugs. Many of you might be following several developments nationally in discussions around the pharmacy benefit manager and their role in the supply chain and pricing of pharmaceuticals. We have, through an analysis of our own data, discovered that there is a difference between what is a fair price to be paid at the pharmacy counter and what managed care companies are currently paying their pharmacy benefit managers for drugs. In some cases, those differences are sizable. So this proposal would align what the state is paying to its Medicaid managed care companies and what those managed care companies are paying to their pharmacy benefit managers to fair pricing at the pharmacy counter. And it implements savings that are associated with that alignment. What we would do in the law is we would require that the managed care company is charged the same amount that the PBM pays to the pharmacy for the ingredient cost of each drug, plus a reasonable professional dispensing fee paid for the pharmacy for their work, and then an administrative fee to the PBM for transacting the business on behalf of Medicaid members. And this, I think, aligns with a lot of what is happening nationally in this space and creates savings to the state and to taxpayers.
Okay, and the next proposal is the elimination of the prescriber prevalence provision. This does apply across fee-for-service and managed care. This provision currently requires us to approve prior authorization of prescription drugs regardless of whether clinical criteria is met. We believe the proposal will ensure appropriate prescribing as well as supporting patient safety. And just to reiterate, Prescriber Prevails currently applies across fee-for-service and to several categories of drugs in managed care. And lastly, some changes to our drug cap enhancements. The modifications that we're proposing, we believe will accelerate our ability to collect rebates. The first component of this would be that we could initiate our rebate negotiations with manufacturers for high-cost drugs by using target rebate amounts that are already established based on published cost-effectiveness studies. We would also be able to negotiate drug cap rebates for high-cost drugs for which there is a manufacturer contract in force. Many of these contracts are not currently achieving the goals as were originally set because there have been market changes. So we would like to be able to sort of move with those market changes and renegotiate those rebates. We would also be able to set our target rebate amounts for these high-cost drugs without consideration of rebates by other drugs by the same manufacturer, and rebates for these other drugs are not applicable or related to the high-cost drugs. And finally, to gain some efficiencies in the reporting to the DUR board by aligning it to the state fiscal year and eliminating the quarterly reporting requirement.
Turning to long-term care, this is Judy Arnold, and the first proposal in the long-term care area is spousal support. It eliminates the ability for legally responsible spouses who reside together in the community to refuse to make their income and resources available for the determination of an applicant's eligibility for Medicaid. And this proposal brings New York into compliance with federal law and regulation.
Hi, good afternoon, everyone. This is Lana Earl. I'm going to talk about a few of the long-term care proposals. The first one will achieve administrative efficiencies related to fiscal intermediaries who perform administrative functions, primarily payroll, under the Consumer-Directed Personal Assistance Program. But before I launch into details, I want to make sure that folks understand that what this proposal is not intended to do. It does not change in any way the consumer-directed nature of the program, and it does not impact hours of care provided to members in the CDPAP program. What it does do is changes the reimbursement methodology for fiscal intermediaries to better reflect the fixed cost nature of the work that they perform, primarily related to payroll, wage withholding, and benefit administration. So that would be the first part of the proposal that would be implemented on July 1st of 2019. Following that implementation, we would achieve some further efficiencies by seeking to consolidate the number of fiscal intermediaries that are out there. There is over potentially 600 fiscal intermediaries out there today. This proposal would seek to consolidate them into several fiscal intermediaries and, importantly, preserve the expertise of fiscal intermediaries who have been in service for a very long time and who are centers for independent living or folks that have a relationship with an LDSS for a period of time going back to 2012. Again, the idea being the ability to preserve that expertise as we seek to achieve efficiencies through the consolidation of fiscal intermediaries. The savings from that efficiency would be $75 million in 1920, the first year it's implemented. The next proposal really just reflects the status of our implementation of 7 consumer first choice options related to environmental mods, vehicle mods, assistive technology, community transition services, moving assistance, home delivered and congregate meals, and community habilitation services. In December, I think it was on the 20th, this state had a webinar giving folks a very lengthy update of where we were, and it was assessment of our readiness needs and reflected requests by other key stakeholders who will have important roles in the smooth implementation of CFCO, including managed care plans and LDSSs. And so we provided some information key to implementation activities that will put us on a path to launch these services in July. And this proposal just simply reflects the status of where we are with the implementation of CFCO as we discussed in December.
Good morning, everybody. This is Mike Ogborn, and I'm going to discuss the nursing home case mix adjustment. So as folks know, we are currently required to update nursing home case mix each year in January and July. This proposal continues that requirement. What it does change, however, is that those updates are currently based on only 2 collection days during the year. This proposal would instead utilize all data available throughout the period to make the case mix adjustment updates in the future. We believe that utilizing additional data points will improve the accuracy of the methodology, and further, it should be noted that this change does not require any additional reporting from the nursing homes.
Hello, this is Greg Allen again. Taking turns here to make this a little more interesting for those of you listening in. So also in the long-term care space, there is a $15 million investment into the State Office for the Aging's expanded in-home services for the elderly program. This program has a capped amount of dollars and regularly supports a waiting list of individuals looking for extra home care. This would implement a $15 million investment that is funded from the Medicaid savings related to this effort. So by allowing these seniors that are non-Medicaid enrolled to get access to additional in-home services through the SOFA AAA network, this would throw off Medicaid savings in personal care level 1 and level 2, not requiring individuals to end up in nursing homes supported by Medicaid, because there would be a preventive feature of providing this non-Medicaid home care service through the SOFA network, resulting in personal care and nursing home savings to Medicaid that are delineated on the bottom of this slide.
Okay, the next proposal will modernize our long-term care regulations to allow for those regulations to better reflect some appropriate reasons that would allow a managed long-term care plan to reduce service utilization based upon a demonstration or reassessment period that would determine that services are no longer medically necessary or needed by the individual. That proposal would have a relatively small impact based on fiscal of the amount of services that are anticipated to reflect that appropriate utilization by around 0.75% of all personal care services, and that reflects the $25 million savings on the scorecard. And the next proposal relates to electronic verification, visit verification requirements. This is a federal requirement that was implemented by the 21st Century CARES Act that mandates that states implement EVV systems for personal care services by January 2020, and then following that up with home health care services by 2023. EVV systems have a few things they must do, but they have to identify the date of the service, the location of the service, the type of the service performed, the time that the service is performed, the beginning and the end time of that, the individual receiving the service, and the individual providing the service, and the type of the service performed. Failure to comply with EVV could result in a reduction in federal Medicaid assistance percentages of up to 1%. And the budget reflects dollars that are for the design and implementation of EVV, and anticipate the federal match at 90% that is provided by the feds for EBV implementation.
Good morning. This is Jonathan Bick. I wanted to review some actions relating to managed care and third-party health insurance. So for Medicaid eligible persons with comprehensive third-party health insurance, such as insurance from employers, they are not eligible for enrollment in Medicaid managed care plans. And if they obtain coverage for under third-party health insurance, they are then disenrolled from a Medicaid managed care plan. So the actions we are taking are designed to reduce the average time from the identification of the comprehensive third-party health coverage to the actual disenrollment from the Medicaid managed care plan, consistent with our enrollment and notification policies. And this will avoid overpayment of capitation to Medicaid managed care plan. It's important to note that those individuals with comprehensive third party who are disenrolled from Medicaid managed care will maintain coverage through traditional fee-for-service Medicaid. So they will not lose their Medicaid coverage. They will just be disenrolled from their Medicaid managed care plan. The second part of this action will realize additional savings that result from managed care contractual changes to recover overpayments when they do occur. This will recoup from the date that the third-party coverage begins until the actual disenrollment. So this is regarding recoupment of capitation payments.
Good morning, everyone. This is Liz Misa, and I'm going to be explaining several Medicaid transportation proposals. The first is the transition the remaining populations and services to the state's transportation management vendor. Back in 2011, the state began the takeover of Medicaid transportation from the counties, and the state currently manages transportation for Medicaid consumers in mainstream Medicaid as well as fee-for-service and operates this benefit statewide. Under this proposal, we are recommending to transition transportation that is included in managed long-term care and adult day health care to our transportation vendors, MAS and Logisticare. The next proposal is to eliminate $4 million for rural transit assistance. Back in 2011, funding was provided to 16 counties to assist with their losses in Medicaid revenue from the state taking over Medicaid transportation. Transition of Medicaid has been completed statewide for some time now, and this transitional assistance to the 16 counties is no longer appropriate. The next proposal is to reduce New York City livery rates by $3 to better reflect market rates. And we are also proposing to adjust Medicaid ambulance rates to reflect the department's rate adequacy report. Back in 2016-17, the department was required to review Medicaid ambulance rates of reimbursement for rate adequacy. And under this budget proposal, the recommendation was to invest $31.4 million in a multi-year effort to increase Medicaid ambulance rates. This budget continues the phase-in of that investment. Additionally, the budget would eliminate the supplemental ambulance rebate payment of $6 million because that payment does not reflect the methodology of the rate adequacy report.
Hi, it's Greg Allen again on health homes. So while this title speaks to health home rate and program modifications, the central feature of this is the program modifications, which are well underway. So we have a an ongoing program discussion right now with our health homes, our managed care companies that all center around developing continuing stay criteria for high-risk health home members, and really trying to make sure that we are focusing our health home resources on the highest risk members, and as members begin to need less support, that they are transitioned off of health home caseloads onto other kinds of caseloads like tracking caseloads that might be managed by the health plans or managed by patient-centered medical home and other kinds of capacities. So the savings in this program assume a very modest reduction in volume in some of our health home enrollment, and if those assumptions prove correct, there would be no rate modifications that would be necessary. However, should we not hit our targets, we are reserving the right under this proposal to make those rate adjustments to create additional incentive to move lower acuity members off caseload, but we are reasonably confident that with the work that's already underway with the health homes and health plans, these savings would be eminently achievable in our multi-year effort to improve health home quality and reduce costs as best as is prudent. Next up is Medicare Part B. So the Medicaid program pays Medicare deductibles and coinsurance for individuals that are co-enrolled in both the Medicaid and the Medicare program. They're affectionately referred to as dually eligible individuals. We have had a multi-year effort to align Medicaid payments in total to providers to the amount that Medicaid would have otherwise paid for a service if the individual was not dually enrolled in Medicare. So this is another step along that process of trying to align our coinsurance and deductible to the Medicaid level. So this would cap our deductible payment for providers and Medicare and Medicaid enrollees to the amount Medicaid would have paid for each claim up to the deductible amount. And then it would close older loopholes that were built on older fiscal realities in the Medicare program that no longer exist, and in the Medicaid program that no longer exists for ambulance and psychologists who are at present statutorily carved out from these requirements that we cap the total payment at the Medicaid rate. And for instance, the psychologist fee schedule has been adjusted by Medicare and Medicaid subsequent to the time that this was implemented. So this closes that loophole and creates the savings noted. Next up is a couple of proposals that seek to continue our efforts to reduce avoidable hospitalizations and reinvest those savings in primary and preventive care. The first of these is we have been working hard since 2015 with the PPSs and all the community partners in building activity sets with the district projects that are focused on reducing avoidable hospitalization. We are happy to report that we've reduced potentially preventable admissions by 17% in the first 3 measurement years of district. So we are building basically a playbook of these district promising practices that have been most fruitful in reducing those avoidable hospitalizations. And we will be scaling those activities and replicating those activities in an effort to continue that reduction in avoidable hospitalizations and helping members to get better care in the community and through ambulatory resources. And then the second bullet and the second initiative here is a very specific effort to create facility-specific reductions for hospitals that have higher percentages of potentially avoidable inpatient services, potentially preventable admissions and readmissions, and reinvest those savings into primary care, maternity, and other ambulatory services. The reinvestment are right now our primary care rates in Medicaid fee-for-service, which continues to be an important service as individuals roll in and out of Medicaid managed care. Those rates right now are as low as 40% of Medicare and have not kept pace with the cost of care. So we would reinvest those dollars into primary, maternity, and ambulatory services. Next up is an effort to fund an evidence-based strategy to prevent individuals that are at high risk for diabetes who currently have what's referred to as pre-diabetes from developing actual type 2 diabetes. It's an evidence-based strategy, fully manualized, been rolled out nationally by the YMCA, called the National Diabetes Prevention Program. This would create coverage under Medicaid for individuals qualifying for this evidence-based weight reduction program that is proven to reduce type 2 diabetes in members that are at risk. The second effort on here is Medicaid coverage for applied behavioral analysts. Again, licensed practitioners that are covered by commercial insurance and the early intervention program for individuals with autism. This would expand Medicaid coverage, A, for children that are transitioning out of early intervention when they age out into age 4, and would also cover children with autism that irrespective of previous coverage by the early intervention program.
Okay. Mike Ogborn again. I'm going to quickly go through the elimination of major academic centers of excellence payments. This proposal would eliminate the state share only grant funding for this program. Funding has existed since state fiscal year 2009-10. However, it's anticipated that over time, GME payments sufficiently cover costs associated with this program. And furthermore, the district investments that have been made over the past few years for similar purposes also cover these costs. As a result, the funding is largely duplicative, so this dollar amount would be eliminated in the budget. Next proposal is the elimination of Population Health Improvement Program. Over the past 4 years, FIP contractors have developed governance structures and networks for collaboration in their areas of operation, thereby reducing the reliance and need for public funds for this program, and these dollars would also be eliminated. The next two proposals, both nursing home transition and diversion and traumatic brain injury, I want to be clear that there are no changes to either of these programs. This is simply a funding switch from the general fund to the global cap, so dollars are moving over from one funding source to another. No changes to the programs. Next proposal increases the non-federal share of the SUNY disproportionate share hospital payments that are going to be funded by the Medicaid global cap by $60 million, state share annually, from $170 million to $230 million annual. And finally, transition of flushing support to value-based payment quality incentive program. This would move funding from the VBP, or from VAPAP, where it currently resides, which is the Vital Access Provider Assurance Program, to VBP QIP, which would free up previously state-only funded dollars in the program.
Very good. Thank you, everyone. This is Donna Frescatore again, and thanks to the OHIP team here for going very efficiently through those slides. We've received a number of questions, and I'm going to ask my colleagues here in the room to help respond to them. We're going to get to as many as we possibly can. We're going to focus on questions that are specifically related to the 2019 to the 19-20 budget. We did get some questions that are on some other topics, and we're happy to have answer those offline if you want to contact us directly. So let's start, Janet, with pharmacy for Janet, Zachary Elkine, and Greg Allen. We got a question on the drug cap slide, asking how the state can further negotiate rebates when there's already a contract enforced, and what in that contract would the manufacturer take precedent?
Yeah, so for the period of that contract, if that contract remained in force, we would, of course, be abiding by the contract. But several of those directly negotiated contracts were done at a time when there were many differences in the drug class. There's new products to market. There are different preferred products and classes. So we would reserve our right to end those contracts and renegotiate those. That, for instance, many of those contracts had trigger points on volume that are no longer achievable. So as volume went up, the rebate would get triggered. And because volume is much different because of new products in the class, the current contract terms are no longer relevant. So we would end those contracts and renegotiate contracts on more relevant terms based on the changes in the marketplace that have occurred subsequent to the execution of those contracts.
Okay, thank you, Greg. That's helpful. The next series of questions we'll address are on long-term care, and Lana Earl, who presented, and Mike Osborne will help us answer some questions here. So, Lana, I think you described this, but again, can you please just kind of summarize the change and the intent of the change in the Article 7 language and the budget related to the consumer-directed program? Before you do that, though, I think I should state, certainly on behalf of the department and the Medicaid program, that we maintain our commitment to the consumer-directed program and to self-direction. And the proposals that we reviewed here today are intended to be administrative efficiencies around functions such as payroll and processing of payroll taxes and benefits. But Lana, can you just, I think you covered it, but just for clarification.
Right, so that was a really great summary, but essentially right now under the CDPAP program, to assist the member with sort of the employer functions, right, including things like payroll, fiscal intermediaries are engaged. And today those fiscal intermediaries are reimbursed based upon part of the hourly rate that is paid for the service. And therefore, the costs today are paid based upon the number of hours that a member receives. And what this proposal really does is takes into account the more fixed cost nature of the administrative functions of the FI, and changes that payment method to a per member per month fee. And that will happen on July 1st. And then the second phase of the proposal would consolidate the over 600 plus fiscal intermediaries that are out there into several fiscal intermediaries based upon a contract with the state that would be procured by FIs who would like to submit a proposal to the state to perform the FI function. And that really could be one or more entities depending upon the folks that apply. The other piece of it ensures that we maintain some of the experience out there today of fiscal intermediaries who have been helpful to folks and who have special experience with members with disabilities in the CDPAP program, and allows those folks to apply. The definition related to who those folks might be relates to the Centers for Independent Living definition that is in the state education law, and then looking back to a period of time around when we took the benefit and put it into managed long-term care, and fiscal intermediaries who are out there serving members with disabilities and have maintained that relationship with LVSSs since that time. Those folks have the option to apply to be a fiscal intermediary when we get to the consolidated phase of the proposal on January 1st, 2020.
Thank you. We also, related to long-term care, Mike Thorne, we had a number of questions about the case mix adjustment. So, Mike, can you first clarify what was meant by all data available, using all the data available?
Sure. As noted, we currently only utilize 2 days in the year for case mix adjustment updates, 1 day for January and 1 day for July. However, we know that nursing homes file assessments multiple times throughout the year. So what this proposal recommends is grabbing all the data available in the assessment period since the prior update to make a prospective adjustment.
Thank you. And then we had a couple of questions, too, from our participants, Mike, on the nursing home case mix adjustment about the calculation. Can you just describe very sort of broadly for the purposes of this webinar how the savings were calculated?
Sure. Yes, currently we just did an estimate based on the data that we have in-house to determine what would happen if we utilized all the data points, as I previously said in my prior statement. So we took a look, and based on the data we currently have in-house, the savings that you see on the scorecard and a reference in the slide deck is what we arrived at.
Okay, thank you. And then there were a number of questions that we got on the electronic visit verification investment. And Lana, you described that this is a requirement of federal law. It's more specifically the 21st Century Cures Act, which mandates that states, including New York, implement an electronic visit verification for all Medicaid personal care services and home care services when there's an in-home visit. And several of our participants noted that the federal law implementation was postponed by 1 year, but nevertheless, this law is still in federal law. So we've got a few questions around that. Let me take the first one, and that is one of our participants asked what is the penalty for a state who does not comply with this federal law, and that penalty is a reduction of up to 1% in their federal medical assistance percentage rate, or their FMAP rate.
Right. So the penalty starts small and escalates up to 1% over a 4-year period, and then grows by an additional 1% after that 4-year period. The penalty starts in 2020 for the implementation of the personal care services side of the proposal, and then it begins in 2023 for the home health side of the proposal. So those penalties would be in play. The federal government has and would look to meaningful progress by states who are, demonstrating efforts to get to an implementation date. So we, as part of this year's proposal on the scorecard, that will help us make meaningful progress as we work as hard as we possibly can to get to that current 1/1/20 implementation date for the first phase, which relates to personal care.
Thank you. And we got some participants asked about a stakeholder work group related to the details of design and development of the electronic visit verification system. And please, by all means, if it's something that you are interested in being at the table for, please make certain that we know that. We've already heard from a number of people and organizations, but we want to make sure that we hear from everyone. And then finally, on EVV, we had one participant note that this year's budget includes an investment for the system, and in fact, it does, and that funding is intended to begin the design and development of a system that would comply with federal law and demonstrate New York's good faith effort towards achieving those dates and avoiding any possible reduction in FMAP. There are no decisions at this point as to who the vendor would be or whether or not it would be a state-based system or a provider-based system, and that would be something that we would explore further with the work group. Okay, great. Let's move on, I think, to another topic here where we got a number of questions. Jonathan, Related to the third-party health insurance recoveries, we've got a question just asking for clarification on who the recoupment of premiums would be made from.
Yes, so the recoupment piece of this action would be a recoupment of the premium paid by the state to the Medicaid managed care plan.
Okay, thank you. And Liz, on transportation, we've got one participant who just asked that we, again, clarify and share some of the thinking and the rationale for why, for the proposals proposed to carve transportation out of the managed long-term care plan, premium rates, and the adult daycare.
Sure. So as I previously mentioned, the goal is to transition the remaining populations to the state's transportation management vendor. Currently, our vendors manage transportation for Medicaid consumers in fee-for-service and mainstream Medicaid. Our goal is to have our transportation vendors as well manage transportation for consumers enrolled in managed long-term care and adult day health care. And I also, wanted to clarify that managed long-term care plans and adult day health care programs are no stranger to working with transportation management vendors. Many managed long-term care plans currently work with a transportation manager to manage transportation in their plan. And we know that over 40 adult day health care programs currently choose to have our Medicaid transportation vendors manage transportation for their programs.
Okay, thank you. Greg Allen, you're up.
Can't wait.
Yeah. A few questions. First, on health homes, can you clarify whether the proposed changes apply to both adult and children's health homes?
Yeah, that's a great question. I should have clarified that originally. So this conversation really about developing continuing state criteria is on the adult side of the health home. We are, still ramping up the children's health home. So at some point in the future, there may be continuing stay conversations there, but right now we are still ramping up and enrolling. So this is really focused on the adult side.
Thank you. And another participant asked about how quality of health homes is being assessed. More to come shortly on that, but do you want to just say a couple of words here today?
Absolutely. So we've been, as many folks who have been close to this know, on a multi-year effort in developing a performance program for health homes, exposing them to dashboards that are in near real time of performance data, and have developed a performance scorecard with input from the health homes and the managed care plans, and we'll be, shortly rolling those scorecards out for multiple years. And I would just say that there were a series of actions that happened last year that have triggered a set of intense conversations between the managed care plans and the lead health homes on enhancing their outreach efforts and on optimizing the engagement of high-risk members and on retaining those members in care management. And we're seeing marked performance increases there, marked performance increases in follow-up after hospitalization, both for emergency department and for inpatient. So robust performance program, and we are seeing some very positive changes in performance, which we'll be talking more about as the months march on here.
Okay, thank you. Also for Greg, we had a question about the Medicare Part B proposal. And can you give a specific example of what the proposal would call for versus, how it currently works?
Absolutely. So two components, deductible and coinsurance. Taking the deductible first. Right now, I think the 2019 deductible, if I'm not incorrect, $185 for Medicare. The way that the claims system currently works, Medicaid for a $100 claim, even if Medicaid paid $70 for that, would be paying the full $100 in satisfaction of that $185 deductible. At this point, we would cap each individual claim to the $70 that Medicaid would have paid. I did see that there was a question up about whether this would be cumulative, and yes, we would be continuing to track what Medicaid paid against that deductible and crediting the next claim for the amount that we paid. So the deductible, once fully exhausted, would then trigger the regular coinsurance, which again would be capped claim by claim to the Medicaid amount. Right now, there's just the two groups on the coinsurance side that are held harmless from this coinsurance requirement. So we pay coinsurance that sometimes is many multiples of the Medicaid rate for psychologists and ambulances. We would now cap that coinsurance to the Medicaid rate. And I think it's important to note that both Medicare and Medicaid have implemented rate increases in both of those spaces at this point, and we are implementing the last of a multi-year effort to enhance our ambulance services here. So those coinsurance caps are against higher rates on ambulance and psychologists.
Thank you. And a related question from one of the participants, and that is whether or not the proposed change would result in a balanced billing for a dual eligible person.
On the Medicaid side, we prohibit balanced billing of members, so no is the answer to that question. If such activity was generated by a provider, we would aggressively pursue that. It's not allowed.
Okay. So a few questions also for you, Greg, about DSRIP. First, I think one of our participants asked if there's a playbook of promising practices available, and I'm pleased to tell you that we will have something out very soon that shows, I think, some truly amazing stories at a very person-specific level throughout the state, improvements in care and DSRIP's ability to access social, to assess and address social determinants of health. So we look forward to sharing that with you very, very shortly. Related to the DSRIP waiver, we have a participant who asked, and maybe Greg, you can clarify any connection between the DSRIP waiver, any renewal, any request to the federal government to renew that waiver, and the budget.
Absolutely. So certainly this conversation around promoting promising DSRIP practices begs the question that since our waiver is scheduled to expire in April 2020, what's next? And we are very pleased, as Donna mentioned, with the performance increases we've seen on not just avoidable hospitalization, but on the range of measures that are that predicate payment in the DSRIP program. And we've seen some remarkable progress on most of those measures and some real, real-life impact on individuals that have been positively benefited by the implementation of the projects and the capacities that have been developed through DSRIP. So we do want this to continue. Many of the CPS have been engaged in performing provider systems, have been engaged in conversations around what a future DSRIP program could look like, and their conversations around different kinds of structures. But clearly, there is an interest in almost all the stakeholders in continuing some version of the best of what's happened here. So there will be a developing conversation over time around what a waiver renewal should look like. Just about everybody agrees that we should ask for renewal. Other states have received approval for more time to basically implement this. And then one last thing, Donna, is that the idea when we started DSRIP and with these conversations going back to 2014 is that value-based payment would be the carrying vehicle for many of these promising practices. And as we stand at this point in our development, value-based payment is not quite mature enough to carry all these capacities forward. So we feel we need more time and are hopeful that our federal partners would understand the need for more time. And so we'll be having more community conversations and stakeholder engagement around not just this budget initiative to promote these promising practices, but also what the future glide path for our, significant demonstration should look like.
Thank you. Thank you, Greg. I've got a number of questions around the investments that are included in this year's budget, and we're pleased that the budget includes a number of investments for consumers and patients in Medicaid. So let's see if we can address those questions. First, we got a question about whether or not applied behavioral analysis coverage would be available to children who were not in the early intervention program, and the answer to that is yes. And we realize that maybe some of the descriptions might have been not as clear on that, but the intention is that it would be for children regardless of whether they had been in the early intervention program, and of course for children who were in early intervention and aged out. We also got a number of questions around the National Diabetes Program, which we're pleased to be able to include in this year's budget as well, including some of the details of the rollout and the fees. I think that certainly is a future discussion, and we will be happy to have more conversations about the details of that proposal along with our medical directors as we move forward. Greg, there were also a few questions about the investment in DSRIP promising activities, including any details that might be available at this point about proposed reductions in reimbursement for avoidable hospital services and hospital services, and any details that might be available about the reinvestment of those funds.
Yeah, so this is important. These two proposals are different. They do link to one another conceptually, but the Promote Promising DSRIP ideas is really that we've been tracking this reduction in avoidable hospitalizations that's considerable. So the simple idea is if we do more of what we've already done through DSRIP, we should be able to further reduce avoidable hospitalizations, and that's the 10 million state share savings. That's literally the idea that if we made a 17% reduction in potentially preventable admissions and we did more of what has worked best in DSRIP, we should be able to impact that, and this is just a little bit of marginal savings along that idea. It is not a rate reduction. The DSRIP one is just about promoting those promising practices like targeting high-risk, high-need individuals, practice redesign, co-location of care management, better transition from inpatient discharge, et cetera. The other proposal, which is our Promote Primary Care and Reduce Potentially Avoidable Inpatient Services, this is a facility-specific, hospital-specific reduction based on peer performance on avoidable inpatient. It's very specifically potentially preventable admissions and potentially preventable readmissions. So we would rank the hospitals on those measures and would create facility-specific reductions to the inpatient rate. And we are very open to, as we always are, conversations with the industry on how to structure this, ways that we can, structure the methodology. The authority is relatively broad on purpose to allow for that stakeholder input in how we would implement this idea. But the idea would be facilities that continue to do really poorly on those measures would get a facility-specific reduction that's higher than facilities that did better, and facilities that, of course, do really well would get no cut. And then we would reinvest those savings into the ambulatory fee schedule for primary care, maternity, and then other targeted ambulatory services. And I did, Donna, see a question up there about, is this a specific increase to the fee schedule? The answer is yes. Our goal would be to bring over a multi-year period the primary care reimbursement in the fee-for-service system and in managed care, up to at least 80% of Medicare, and we do that by creating very specific benchmarks in Medicaid. This year we're trying to lift to roughly 65% of Medicare and then align the midwife and nurse practitioner's schedule to that rate at 85% of physicians.
Thank you very much. So we are at the top of the hour. I'd like to thank the team here from the Office of Health Insurance Programs, and thank you for joining us here today. You see on the screen where information, I think where to reach us. Today's slides will be posted on our website, and a recording of today's webinar will also be available. If we weren't able to answer your question, or if you had a question that wasn't directly related to today's budget presentation, please email us at the mrtupdates@health.ny.gov website, and we'll be happy to answer your question. Thank you again for joining us, and we'll see you soon.